Good. Management of cholesterol and lipid disorders. How many of us saw one WhatsApp message that said cholesterol is fake? Who remembers that message that went around the whole of the country? Patients dropped it and said cholesterol is no longer something. One American, somebody, please. What is those kind of useless messages? Delete it and send back to the person that, okay, let me not say what I will say, but you understand what I'm trying to say. Send it to the person. So now let's get ready. We're going to start straight away. Am I going up or down? Good. All right, so we want to understand lipids, cholesterol. We want to review some assessments and targets. What, why, how the problems happen, how do we manage and evaluate, how we manage. After this lecture, you're going to realize that perhaps you have not been managing cholesterol well. 80% of us, and we're going to see better ways to do things. So what is all of this, and why do we care? The reason we care is that cholesterol and lipoprotein metabolism is central in atherosclerosis. Atherosclerosis is the first and main basis for strokes, for heart attack, for peripheral artery disease, and cholesterol and lipid and lipoprotein metabolism is very critical. Also involved in pancreatitis, liver disease, and to help us with treatment. But most of the cardiovascular disease, which is why we are here in this meeting, is cholesterol and lipid metabolism at the center of it. So that is what we are learning. So why is it important? You can see that it affects the brain. It is involved in dementia. It is involved in sight. It is involved in enlarged hearts, in ischemic strokes, kidney failure, heart attacks, aneurysm. It's like everything is particularly involved in. So that's what we are learning. So what are lipids? We're going to learn these things. Lipids are a group of oils, fats, waxes, and compounds. That is lipids. Under lipids, we have a group called sterols. So lipids have several subdivisions. Fatty acids, glycerol esters, pherols. Okay, so again, lipids, we have sterols amongst others. Under sterols, we have cholesterol. Okay, so that is the relationship between all of them. So under sterols, we now have cholesterol. Now, cholesterol is what we are looking at. It is the main sterol in man. It has lots of good things. It's used for hormones. It's used for balanced metabolism. It's used for vitamin D. However, what then happens? Why is it a problem? In this landmark study called the Framingham Heart Study, this is a landmark study in 1984, published in 1984. It was recognized that as cholesterol increased, so did coronary heart disease. The higher. Almost a linear relationship, and this bettered the origin of all cholesterol management. You are being shared with some risk profile charts. So what are lipoproteins? We've talked about lipids, right? We say lipid is the umbrella body, right? We said that under lipids we have sterols, right? We say cholesterol is one of the sterols, which is important. Now we have lipoproteins. Lipoproteins are simply, because lipid, oil, does not mix with water very well, it now needs a vehicle to carry it around the body, and that is what lipoproteins are. Lipoproteins are the shell that wrap the cholesterol and allow the cholesterol to move around to where it is being used. Do we understand that? Good. So, then we now have another subset. So, if you look at it, lipids, the cargo, lipoproteins are the trucks that carry the cargo. We will go on. It's going to get a little bit more complex. Then what are apolipoproteins? Are we getting confused? Are you confused? Yes. So, we have lipids, all oils, right? Then we have cholesterol, a type of sterol, a lipid. Yes? Then we have lipoproteins. Lipoproteins are the ones that carry the cholesterol so that the cholesterol can enter, since oil and water no they mix. Abi? Correct. Then we have apolipoproteins. Apolipoproteins are the protein part of this, and I will show you a diagram. So we have cholesterol. Cholesterol enter inside these vehicles. Those vehicles are the lipoproteins. The protein part of those vehicles or the tires of those vehicles are apolipoproteins. Is this clear now? Cholesterol is transported by these lipoproteins inside their trucks, chylomicrons, all of that. And apolipoproteins are the key component, are the proteinous components of this. Is this clear now? Hello? Don't get distracted by food, though. You are here. I can see some people that came from Lagos, from Katsina, from Gigawa. You came a long way. So don't get distracted now. Just eat quietly. And if you see that we refuse to bring small chops today so that we will not raise the cholesterol. Okay, so those of you waiting for puff puff, please. So we can see that. So let's move on faster now. Where does cholesterol come from? There are two ways cholesterol comes. One is endogenous, another is exogenous. Exogenous is from diet, right? Like we talked about puff puff, abi? Oily food is from diet. And the second way is endogenous, which is why if you say you are not going to eat from now till next year, doesn't mean your cholesterol will not rise. There are people that will say, I am slim, I am not eating, why is my cholesterol still high? Can you see that? Because all the cholesterol does not come only from diet. Some is produced internally endogenously. Is that clear? This is why diet alone is not always sufficient to control cholesterol. So a lot of times you need to add drugs, and I will tell you at what point you add drugs. So diet comes there. So this is how we now do our treatment. We have these treatments acting in different areas. When we tell somebody to do a good diet, it's acting exogenous on the diet. When we give a drug called ezetimibe, just think ezetimibe. Abi? Ezetimibe and awesome. You are with me? It's from Nigeria. Ezetimibe works on mucosal absorption. Statins, atorvastatin, rosuvastatin works endogenously to prevent at this point. While PCSK9 inhibitors, which is the new one on the block, which Novartis wants to present now, works on the receptors. So on the receptor there, that receptor helps to mop up cholesterol, LDL. So these inhibitors stops these receptors from going away so that it can mop up more cholesterol very fast. This is essentially, if you understand this, you understood everything about cholesterol. Should I go right again? Oh, wow. That yes was we said all lipids are good for the body. Abi? The body has lipids. The body now has a subtype of lipids called sterols. And cholesterol is one of that. Cholesterol in itself is very good. It helps the body to create steroids, hormones. It helps the body to create cells, cell walls. Abi? Cholesterol. Now, what now causes the problem is the lipoproteins. And we say the lipoproteins are simply the trucks that carry the cholesterol. Do we understand that so far? We now said that the cholesterol comes from either internally, endogenously, where it is being made in the body, or exogenously from our diet. And that when we want to control it, we either control from the diet, directly what we are eating, taking a drug that affects the absorption, or allowing it to be metabolized quickly with the PCSK9 inhibitors so that the LDL will move it out quickly, or we stop it from being formed internally. Do we understand this so far? Simple, isn't it? Very, very simple. Now we'll go a little bit deeper. I just need to understand this. When you understand this, you will know why sometimes you should not just say diet alone. Sometimes also you should not say drug alone. Can you see that drug will not affect diet alone? So you need to put in all of this, and sometimes you need to do multiple. You need to give the one that stops absorption. You need to give the one that stops this one. You need to give diet. You need to give PCSK9 inhibitors if you must get good control. Good. So now we understand that. I'll leave this big English. If we look at all of these trucks, these are the lipoproteins carrying cholesterol. Remember, lipoprotein is the truck, lipid is the cargo. Again, lipoprotein is the what? Lipid is the cargo. Awesome. The different kind of trucks do different things. The LDL cholesterol carries it to the tissues, and that is one that causes a lot of problem. You can see it's in red. The HDL is the cleanup truck or recycling truck. It carries it away to the liver for metabolism and gets it out of the body. Can we see that? The VLDL is combined in between, and the chylomicrons carry the fat one. Can we see how this works? So when we are, which one do we want more of among these lipoproteins? HDL, that is why we want a higher HDL. Which one do we want less of? LDL, we want less of it, and also the chylomicrons and the triglycerides, we want it lower. That is what we are trying to do. And we say it can be endogenous and what? Exogenous. Awesome, you see? You're already lipid, lipid specialist. So now, how do we treat? How do we treat? Anytime we want to treat, having looked at all of that, treatment is in multiple functions. One, diet. Diet. Why do we use diet? Because exogenous, right? Lifestyle. Why do we use lifestyle? Exercise and the like. Because lifestyle enables HDL to increase so that it can take more out. It enables things to be burnt. What else do? We treat any secondary causes, obesity, hypothyroid disorders. All those things can also increase cholesterol exogenously. Then we give medications. And under the medications, we have different types. Statins, fibric acid derivatives, and all these big names. But we're going to focus on 3 in our treatment one. The one we're going to focus on primarily is statins, AZE, TIMI, B, and PCSK9 inhibitor. If you know those 3, you will have mastered cholesterol, metabolism, and therapy. But before we treat, who we treat, how we treat, depends on risk. We are not treating numbers, we are treating risk. When we are treating hypertension, we are not treating numbers, we are treating what? Risk. When we are treating diabetes, we are not just treating numbers, we are treating what? Risk for what? Anybody, risk for what? Cardiovascular disease, CVD, risk for stroke, heart attack, limb amputation, kidney failure. That's what we are treating. Those numbers in themselves don't mean much. If you bring out the number, you don't take care of the total risk, you may not have treated the patient well. That is why we are here. Okay, good. So let's go on. So in 4 groups of people, we recommend drug treatment. Those with already established cardiovascular disease, they already have significant chest pain, ischemic heart disease. They've had a stroke. They have established cardiovascular disease. Thank you very much, Ma, for that fantastic, deeply intellectual lecture. Very, very deep. Thank you very much, Ma. So I'm not doing much again. I just have to. Those with ASCVD score greater than 10% or greater than with diabetes. Once they have diabetes, how many people have downloaded the calculator now? Anybody downloaded the calculator? 1, 2, 3. Hey, not up to 10%. Oh. If you have WhatsApp on your phone or Instagram and you don't have this calculator, you are not a good alumni of this meeting. You must have this calculator because you must. And it's very simple. To ask what's the age of the patient, you write it. If you ask is it a male or a female, you write it. At the end, it will give you a number. That number is what we're talking about. If the person has diabetes and that number is 10%, they need drugs. Don't say, doctor, let me go and remove oil in my food. No, they need drugs. If the number is more than 20%, they need drugs. If they are LDL was it the good or the bad one? The bad one, carrying the cholesterol, Abi. If that LDL absolute number is more than 190, they need drugs. Okay, so that is what we are doing here. So I will not speak about this big English. No need for all of that. All right. Now there's a new kid on the block. We started using this in Cardiocare recently. It's a lipid lowering agent called PCSK9 inhibitor. I think Novartis is the first to bring it to the country, called inclisiran. And essentially, it allows LDL receptors to stay longer, to clear the cholesterol from the body. That's essentially what it does. Just allow those receptors to stay longer, to clear and reduce the LDL. We normally don't use it for everybody. It's only when other typical therapies have failed that we will now start to use it. So let me see. So I will leave all of this. There are 2 types of dyslipidemia, abnormal lipids. 2 types. How many? Please talk with me, Otherwise, you will come stand for here with me. If I see you not answering, I will just call you. Except the military people, I know you can. The remaining people, I can call you. There are 2 types, 2, primary and secondary. Primary and secondary. A lot of people have primary, meaning in their genetics already, they already have a tendency towards high cholesterol. And sometimes we see them with primary, they have premature heart disease. Less than 40 years old, developing an MI. And we've had a number of them in Cardiocare. People with family history of 3 people in their family have stroke. I've put stents for 3 members of one family. One cousin, one brother, one uncle, all of them, they say, they're just coming one after the other, after the other, after the other. But they already had several history of sudden deaths. Okay? So they have now been coming. 3 of them at least that have put stents. So not to talk of the rest in the family. So those are people that we investigate for primary dyslipidemia. Okay? So, and you see signs like this. You will see these kind of things on the legs. These are called xanthomas. And then you see things like this, acrocenilis, you see things like xanthelasma on the skin. That points to us that, and then of course secondary ones caused by something else. When do we start screening for dyslipidemia? Everybody above 35, men above 35, women above 45, should have a cholesterol test. You must not be old, more than 60 before you start doing cholesterol. Number 2, if there is a family history of coronary artery disease, diabetes, hypertension, from 20 to 35, you start your treatment. You start your screening. When they come in at that age, you start your screening. Okay? Very, very important. Now, what is the cutoff? What is the cutoff for treatment of lipids? How many of us have those lab results that will say normal LDL from this one to this one? We have that in our clinics, yes? When you go back, go and scratch it off. Erase it. Tell them that we said that you have a certificate from ACS 2025. You hereby please, but do it quietly. Don't lose your job. But very important, those things don't make sense because it depends. The normal value what? Depends. What does it depend on? It depends on their risk category. Look at the LDL. For those with extreme risk, the normal cutoff should be less than 40. If you see 80, they are in trouble. That is, they've had recurrent stroke, recurrent MI. The normal should be less than 40. For those with very high risk, they've had an MI, they've had a stroke, they have peripheral artery disease, their normal should be 55. Some of us will see that number and say, your LDL is 50, is 70. Don't worry, you are doing fine. Just continue what you are doing. You are not doing fine. Hello? We are here to unlearn, to relearn, and to learn. So you need to go back now. All those patients you mistreated, you need to call them back and say, well, I just came back. I just got back. IJGB, Abi? Good. Then those with high risk, they have diabetes, CKD, or they have very significant high risk tests. We start looking at 70. And those with moderate risk, we look at 100, and those with low risk, we look at 116. These are targets that we are looking at. So, how do we now determine those risks, what level they are? We have a risk treatment approach. If you see they gave you some charts, how many of us have those charts? I never got those charts. Can I have one of those charts, please? Some of us have some of the charts. You can use the charts. They gave you some charts. Did it go around? You didn't make up to 1,000. They were expecting 200 people or something. All right, so let's use this approach. 5-step evaluation of dyslipidemia. Everybody, just focus. If you don't have it in your hand, if you have it, you already know. If you don't have it, just focus. You can use that chart, or we can use this one. So if the chart goes around, we'll use it. 5-step evaluation. So if yes, jump to the next level. If no, jump to the next step. So any patient that comes, number 1, first question we ask. Thank you so much. So this one is very big, Abby. So some of you have it, some of you do not have it. If you don't have it, we'll try and make it available. Hopefully we'll have some more tomorrow. You can use this one, anyone that is red, green, yellow. The risk is here. Or you can use the calculator. Okay, so you can use this one. But this is a very simple one. Level A, is there ASCVD? Yes or no? Yes or no? Is there ASCVD? Yes or no? If the answer is yes, we jump to the next level. No need to continue. But if the answer is no, that is, does this person have MI? Stroke? Abi? Remember them? Does he have any of this? No. Fine, we'll now move. Very high risk they have had or they are impending. Stable, they are not having anything that is ongoing now, but they had been in the past. Extreme, they've had more than 1, 2 strokes, 3 strokes, 2 MIs, 3 MIs. They are extreme high risk. What is the target for extreme? Who remembers? What? The rest of you that go fail the exam, oh, your certificate go lost. May not be like say, we'll do your leg over. Good. So, extreme multiple events, very high risk. They have an ongoing cardiovascular disease, stable. They have a history of cardiovascular risk. They are still very high risk, but not in that regard. Then the next one, if they don't have that, we now go on to calculate what is their ASCVD risk score with that calculator we talked about. Or using this chart. You can see low, medium, high, very high. You use that one. If now that passes and everything, they are very low, so they may not need anything, the next thing you ask, is the LDL above 190? If the LDL is not above 190, just lifestyle and diet. If it's above 190, then we go on to medications. And then we follow up and escalate. Is this clear? We are going to do examples, don't worry. So number 1 question, does the person already have a disease, cardiovascular disease? Number 2 question, what is their risk for developing a cardiovascular disease? Number 3 question, is their LDL very high? If yes to any of these ones, they need to start drugs. If no, then you can now start lifestyle. Very simple. And then you continue to follow up thereafter. So let's look at a patient. Sorry. Is there a way you can walk better? I don't know whether I'm going forward or backward now. I'm going back. Okay. Okay, good. So let's do an example. 58-year-old man, hypertension, not diabetic. Please bring water to the front, please. Not diabetic, minor stroke, 3 years ago. LDL 92, HDL 38. How will you manage? Anybody? How will you manage? Drugs alone? Hello, sir, I like your shirt. What will you do? What will you do? This man, 58-year-old, let him go and come back in 2 months. Give him drugs. Let him start exercising. Huh? Diet, lifestyle. What did we say? What did we say? We had a 5-step. What was the first step? What was the first step? Is there an ASCVD? Yes. If there is an ASCVD, straight, start treatment. If any of them has yes inside it, start treatment. Abi? Very simple. Since the man has had an ASCVD, he's very high risk. What is his target? Not 40. Less than 55. 40 is for extreme high risk. What are extreme high risk? Those that have had multiple events. Maybe he has had 2 strokes. Hello? So this patient now, is his cholesterol well controlled? We are aiming for 55. He's on 92. He already has an ASCVD, a stroke. Forget minor. All those English, I had partial stroke. They don't exist. They had stroke or you didn't have stroke. Nothing like minor, nothing like partial stroke. Delete it from your vocabulary. You have come here now. Delete it. All right. So, let's see. So, is there ASCVD? Yes. So, we just go on and then we start treatment straight. Once there's ASCVD, we don't have time to talk again. After that, we start lifestyle, diet, and medication. We want to get him to target less than 55. And then we want to follow up. For him, is his lipid normal or abnormal? Abnormal, Abi. So every 3 to 6 months, you must check again. In his case, every 3 months, because you need to get to target within 3 to 6 months. If you are not getting to target by 6 months, you need to add another drug to this treatment. And you need to start with very high statin. This man is at very high risk for another stroke. All right, so stable, very high risk. We've talked about this before. And then, so, for this man that is very high risk, our target must be 55. You must start with maximally tolerated statin. You're not giving atorvastatin 10 milligrams or rosuvastatin 5 milligrams. That is quackery. Say it together, quackery. You are here, don't worry. You are not one of them. Abi? And when you go back to your clinic, to your hospital, you will go and change the thing. So now, we are saying this man has had an event. He is very high risk. He has had an ASCVD. We need to get to his target very quick within 3 months. And we want to start with maximally tolerated statins immediately. And if we don't get control very soon, we start with something. So whenever you are given a statin, start at the recommended intensity. You should get your target within 3 to 6 months. This man's target is what, again? Those at the back, I can't hear you. Anyway, you go do tests. No worry, I go hear you that time. So the target is 55, Abi. In 6 months, if this 3 months is not at 55 or 6 months is not at 55, please add another one. Otherwise, this man will come back to you. If he has diabetes, even worse. By the time he has diabetes plus a previous stroke, then you start playing around with, okay, remove oil in your diet, come back in 3 months, let us check. You are not doing them a good service. Okay, fantastic. All right, so how do we escalate? Everybody must have the lifestyle. What is the lifestyle? These are acronyms for heart. Healthy diet, exercise, avoid smoking and alcohol or reduce weight, and treat comorbidities. Everybody, you can see, is going up. If they qualify for diet like this man, you start your statin. If there is no control within 3 to 6 months, you go and add azacitidine B. If azacitidine B is not available, like it's not very much available, you can give this PCSK9, which we are talking about, say twice yearly injection instead of a daily dose drug. In addition to statins, not on its own. I know there are some studies trying to check a bit how it works on its own. In addition to statins. So if that's not available, you now go straight to that. Or bempedoic acid, which is also not very much available. I hope this is clear. Everybody, lifestyle. Then, for these people that qualify for drugs, start drug. If the cholesterol is not at target within 3 to 6 months, add azacitidine B or PCSK9 injection, which is an injection. It's expensive, but it works. You could see some patients that have been struggling with cholesterol. I think we have one patient like that. Had an MI, has had 3 stents. Cholesterol is still 110. For us, we know that is a very, very high. So forget that thing that they wrote on the lab. His target should be what? He's had 3 stents. He's diabetic. What will his target? 40, because he's extreme high risk. And he's having 110. By the time we started the injection, it started coming down. So very important, in addition to statins, not on its own. So very high intensity statins. All right, so case 2. 54-year-old man, DM, hypertension. We put a stent for him 1 year ago. He's on atorvastatin 40. He's on insulin. He's on ACE inhibitor. He's on beta blocker. He's on aspirin. Total cholesterol 198. LDL 120. HDL 38. What is your advice? Pray about it. Repeat in 3 months' time. Go and start reducing oil. Bath with Zobo. All right. So what's our target here? Or what should we do? Let's go back to our algorithm. Let's go back to our algorithm. Oh boy. Oh boy. What is this? Okay, fine. Let me show you the stent. Let me show you the stent. Can we see 100% blockage there? This artery should have formed like a C, complete C. That is 100% blockage. We're having severe chest pain. That's a wire. That's my wire going through. Small wire. Passing the blockage. Can we see that? Pass the blockage all the way. That's my blom. Put a blom. I did this one through his wrist. After putting blom, can we see the artery now showing up? Is that clear? So we now put the artery, we gave some drugs, then we now put some stent. The stent is like scaffolding to keep it open, otherwise it will close back. So I had to put in 2 stents for this patient. Okay? And then, thereafter, we can now see the blood vessel. Can we see the blood vessel? Remember where it was before? Now, all this part of the heart was not getting any blood supply while he was having that chest pain. And somebody was treating him for ulcer. It was until his blood pressure dropped to 80-50, they now started running around. So that is very important. So this kind of person now, he has had that thing now. LDL is still 120. Despite statin, you need to begin to escalate the treatment. So when do we add ezetimibe? Anytime the patient has had ASVT and is still greater than 70, you are still having uncontrolled, you need to now start adding all of that. Okay, let me move fast, and I think I will end here. Are there any questions? Let me end here. Are there any questions? Do we understand? Are there any questions? Remember, anybody comes with LDL, cholesterol to you. At what age do we start screening? 40, Abi. 35 in men and 45. You know, men die faster. So 35 in men, 45. By the way, if you Google country with the lowest life expectancy, guess which country shows up? Unfortunately. And this is one of the things that we have to work on. As in, it's very painful. You just Google it, just out of courtesy, just somebody said it, I say it's a lie. And I Googled it and it showed up. Hi, I've never lower than Sudan. Niger. Lower than the place where they are fighting war. Hi. Anyways, back to what we are doing. And this is what we're talking about. So, first of all, we ask ourselves, have they had a CVD? You are checking it, Abi? Is this still true? Hope somebody has overtaken us, hopefully. It's still true. Hi. Somebody should worse than us now. The people have gone, Abi. Please don't put this on the... All right. So, have they had a CVD? Question 1, Abi. Question 2. What are the questions now? Talk to me. Question 1. Have they had a CVD? Yes or no? Question 2. Zaba. Talk. Yes? You say what? ASCVD score, Abi. The risk score. What is the risk score? Diabetes greater than 10%. Then, if that one is, everything is fine, less than 10%, what do we move next to? The absolute LDL level, greater than what? 190. If all of them are positive, you need to start treatment. And then after that, you follow up. For those that have abnormal one, how often do you follow up? 3 to 6 months. For those with extreme high risk, repeated events, or they had a CVD and they have diabetes, what is their target? 40, less than 40. For those with a single event, what is their target? 55, and then the other 70 and 1. This beautiful. All right, great. So I'll take a question now. Yes, please, microphone. We are now lipid managers. So there's somebody there. Come to this side. Yeah. Please move fast. Time is gone. Novartis. And then if we now talk about escalation, what do we start first with? What do we start first with? Science. Lifestyle and diet. And we said they are HEART. H is for what? Healthy diet. E is for what? Exercise. A is for what? Avoid smoking and reduce alcohol. R is for what? Reduce weight. T is for what? Three comorbidities. Good. Then we now move to what again? Statins. Maximum tolerated dose. Then we now move to what? Azacitidine B or PCSK9, inclisiran. Then we move to that one. Okay, that's how we escalate. Beautiful. Yes, somebody had a question.
Thank you very much, sir. Please, wanted to ask, the drug treatment, is it for life?
Okay, so in most cases, drug treatment is for life. Has anything changed recently? In most cases, drug treatment is for life, especially for those with their ASCVD scores high. If they've had a cardiovascular disease, their drug treatment is for life. That they've had a stroke, they've had an MI. You need to keep it consistently at that level or below. If they've never had any of that and their ASCVD score is less than 10%, so all those things were no, only that their absolute value was greater than 190. Once you get it below and you are doing diet, exercise, and the like, you can stop. But if they've had an ASCVD or are at very high risk, 99% of the time it is for life, except they are intolerant of it, then you can now find a way of modulating it. Of course, Prof is here, she can modify that. Yes. Good. So, over to you. Thank you very much. I'm sure that will be value for your time.